Hello. Today we're going to be discussing artifacts versus arrhythmias. This is not just a presentation. I consider it a lifeline because these are real life situations that we will have to make clinical decisions on. This can save lives. It can also stop panic before it starts. Um, why does this matter? It matters because if you can um, detect an artifact and not panic over an artifact, you would avoid unnecessary CPRs, shock, or missed real life emergencies. Commonest areas where even the consultants fumble, you're going to identify that. And by the end of this presentation, you'll be able to spot an artifact in less than 5 seconds. You know when to trust your ECG strip. You can save time, protect your patients. Now, what is an artifact? An artifact is any ECG change that is not due to a cardiac electrical activity. It mimics an arrhythmia, but it doesn't come from the heart. And the sources include muscle tremors, say a person is getting shakes from shivering, patient movement, loose electrodes, electrical interference, and like I said, shivering or shakes from Parkinsonism or hypothermia. You will get what looks like an arrhythmia, but it's not an arrhythmia. It is actually an artifact. For example, if you have loose leads, let's say that there's poor lead attachment, you can find flat lines, you can find sudden breaks. If there's movement during the reading of an ECG, you can have odd complexes, what's looking like bizarre complexes. You can have rhythmic spikes. And also, if there's electrical interference, you know, at maybe about 50 to 60 Hertz, you can have problems with your ECG strip as well. Now, the key features of an artifact is that there's no consistent QRS morphology. So you see some bizarre complexes or maybe some bizarre QRSs, but that's not being repeated. That's not consistent in across your strips. One lead may be normal while the others are chaotic. No logical progression of your PQRST. And what you find is that the pulse does not match the ECG rhythm. It starts and ends abruptly. um, Always ask, does the patient look sick? So the example I like to use is, for example, with the ventricular fibrillation rhythm. You see the rhythm on the strip and it looks chaotic, like a ventricular, like your V-fib. And you know that your ventricular fibrillation is a shockable rhythm. It's a rhythm that is also not compatible with life. And then you look at the strip that they give to you and you're saying that, but you ask, how is the patient? Or, you look at it in shock and you're like, oh, where is this patient? How is this patient? And they tell you, oh, look at the patient. And the patient is just busy having a cup of coffee, talking to the nurses, just, that is not compatible with life. There is no way that a ventricular fibrillation ECG per patient will be standing or talking or walking about comfortably. And then you should ask for a repeat ECG because that must be a wrong ECG, maybe for the wrong patient, or an ECG that is an artifact, that is showing artifacts. And the clues are the baseline irregular but QRS the baseline irregular, but the QRS is consistent except in one lead. Is the patient clinically well despite the ECG, like we mentioned in the case of the VFib? Are the limb leads more affected than the precordial leads? That would show you maybe the legs are moving or the arms are moving rather than the precordial leads. Are there muscle activity near electrodes? Um, you is there, do you, when you repeat the EC, just does your initial finding, does it clear up? So this is an example of what could be an artifact. I see this quite a lot. Artifacts are more common, arguably more common than the actual bad rhythms in emergency department from experience, because what you find out is that whether the leads are poorly placed or there's poor lead attachment or the patient is shaking, is not cooperative, or is a very quite maybe agitated or shivering or quite active while this is being done. Of course, you should always think of the pathology. The reason why they're in the emergency is to rule out a pathology. So always keep your mind open towards a possible pathology. But again, that's why I say context is key. And if you're in any doubt that this could be an artifact, you repeat the ECG, ask for a repeat ECG. Now, for you to confidently say that you are identifying an artifact from an arrhythmia, you've got to know the types of arrhythmias that we have. Now, we've talked about identifying a sinus rhythms in the throughout this course. We've talked about making sure that your P wave is upright in your lead 2, 3 AVF and is inverted in your AVR. We've talked about the fact that your P wave must follow a QRS wave. We've talked about the fact that your rhythm must be regular for you to consider it being a sinus rhythm. And you already know about the characteristics of a normal ECG. And we've talked about the fact that a normal sinus rhythm is premised on the fact that the rhythm is being generated in the pacemaker of the heart, which is the sinoatrial node, and that there is normal conduction through the sinoatrial node to the atrioventricular node to the bundles of ears, and then through the Purkinje fibers. We've talked about the rate. What would mean 60 to 100 beats per minute. We all know that that's the normal heart rate. However, in sinus bradycardia, sinus bradycardia is still considered a, so to speak, a normal finding in a lot of patients. For example, if they are young, athletic, if they are sleeping, if in sick sinus syndrome or MI, however, they are pathologic. Now, in hyperkalemia, you can have sinus bradycardia as well. So normal in a few cases, like if they're sleeping, young, athletic individual, pathologic if they have an excessive vagal tone, sick sinus syndrome, MI, digoxin toxicity, sedatives. The clinical signs you will have in pathologic sinus bradycardia is you will have low perfusion, lethargy. You could have changes in the mental status, poor capillary fill, mottled skin, low urinary output, and syncope. So that being said, yes, we move on to the next slide. Now, what would you do if there was bradycardia? If there was bradycardia, you would want to document the reading, notify the doctor if you were the nurse, and also if you were the doctor, you want to get your team on board. You want to give oxygen, especially if you're doing their saturations or their vitals. You want to consider atrial pain. You want to prepare for external pacing if they're hemodynamically compromised. We've talked about shit. We talked about syncope, symptoms of heart failure, symptoms of ischemia, and if they're dizzy or any of the vitals, they're hypotensive, right? You want to prepare for external pacing in those cases. And if they have premature ventricular complexes, you make sure you do not treat with lidocaine because, this is the heart's attempt to improve perfusion. And then with atropine, you want to consider zero point 0.5 milligram. Now, if you're taking this decision and you are a junior doctor, you actually do want to get the cardiology team on board, before you give all of this, except there is no help on ground and you're the only one on ground and you think that they are hemodynamically compromised. If they are very well, if they are well in themselves and they're having sinus bradycardia, you may want to hold off on all these bits. But if they're hemodynamically compromised on well, they're at risk of going into a cardiac arrest. Then you want to go in with, at this point, which is zero point 0.5 milligram IV. Maximum dose is 3 milligram. You repeat this 0 0.5 milligram or 500 micrograms. You repeat it in every 3 to 5 minutes. Do not give less than 500 microgram. It can worsen the bradycardia, and do not push slow. Now, the mechanism is that we're talking about sinus tachycardia here. So in sinus tachycardia, the mechanism is increased automaticity of the sinoatrial node with normal condition. And ECG characteristics is that you find, apart from a faster heart rate, the other characteristics are normal. Sometimes because of how fast it is, you find your P wave merging into your T wave. Now, in sinus tachycardia, that's a natural response to environmental stimuli like pain, fever, exercise, and the drugs that are the culprits would be caffeine. So if you've been preparing for an exam and be overdosing on caffeine, alcohol, remember the alcohol holiday syndrome. Sometimes alcohol even triggers atrial fibrillation rather than sinus tachycardia. Also in hypothyroidism, in shock, sometimes what you have is sinus tachycardia, and that will be paired with your hypotension. Then your congestive heart failure, your hypoxia could all be in tandem with sinus tachycardia. The clinical signs involve the fact that there's increased workload of the heart. So there's shortness of breath, anxiety, chest pain, hypotension, and low urinary output. There's low perfusion. By the time you get this kind of clinical signs, they are becoming hemodynamically compromised. And if they are symptomatic, you want to document the reading, inform the clinical team, including the doctors, apply oxygen, treat underlying cause, may consider vagal maneuvers. That is, where you tell them to cough, bear down or blow through the straw, or try, blowing plunges of the syringe. The mechanism for um this is sinus arrhythmia. Sinus arrhythmia is a normal phenomenon that occurs with inspiration. So I've seen quite a number of cases where the primary care doctor refers to the emergency, no, to the hospital, to the cardiologist and says, "Oh, this looks like an abnormal rhythm, like maybe an atrial fibrillation. What do you think?" And it comes up being sinus arrhythmia. And now you will know this is sinus arrhythmia. There's a clear P wave. You find a clear P wave throughout your rhythm. That's one clue to alert you. And you will find that there are no other abnormalities with this patient. This patient is having most likely a normal heart rate. Now, it could also occur however, bear in mind that it could occur with myocardial infarction, raised intracranial pressure, digitalis toxicity. You could have this in fever, anxiety, shock, document the rhythm, and notify the doctor or the entire team if they're symptomatic. Like I said, in many cases, what has been referred from primary care is where they are asymptomatic, right? And they are normal heart rates. And apart from the fact that this looks irregular somewhat, what you find is that there's clear P waves. There's a good P wave morphology in all the leads, and you can see it here. What happens many times is the rate increases with inspiration, drops with exhalation, and what you will find is reflex vagal tone inhibition. And so it will look irregular somewhat, but it's just associated. Patient was just holding their breath. Now, with sinus pause and sinus arrest to sinus block, what you have is high vagal tone or increased vagal stimulation. Heart rate is less than 50. So it can also occur in pathologies like a myocardial infarction, if they've had cardiac surgery, sinoatrial node disease, metabolic disorders, lupus. Now, if the heart rate is less than 50, they could this is most likely a sinus pause, and you're having what looks like an irregular heartbeat. Now look at this what we this is a sinus arrest. The basic rhythm does not resume after the pause, so this is like a 3-second pause, or if you count this, you do count this. But what we worry about with sinus arrest is if this pause is more than 3 seconds. If it is less than 3 seconds, we may watch wait, we may decide to manage conservatively, involve cardiologist or not. But if this pause is more than 3 seconds, then you are going to be very worried. In atrial dysrhythmias, what we discussed things like premature atrial complexes. Now, in premature atrial complexes, the rhythm is irregular. It makes you think of, oh, could this be irregularly irregular? Could this be atrial fibrillation? However, because the rate varies, right? Like an atrial fibrillation picture, the rate varies. But again, you have good, clear P waves. But what you find is that the P wave is different from the P wave in another. So you have unclear P wave morphology. I would like to annotate here. So if you look at the P wave here, compared to the P wave that you're finding, and you look at the P wave here, compared to other P waves, right? It's an abnormal morphology, and the PR interval varies during the beat. So the T wave may also be distorted, but what you have is that the P wave morphology is different. And so the premature atrial complex is occurring before the normal P wave. And so you can pick it out here. You can pick it out here. The etiology is usually from stress, stimulants, alcohol, overeating. In many cases, it is benign, but be alert because this will also occur in the setting of an electrolyte imbalance, drug toxicity, pericarditis, MI, ischemia, COPD. If you have greater than 10 packs, consider the possibility of a congestive heart failure, and they could also present with palpitations. Document, treat underlying cause. Now, in atrial fibrillation, this is arguably the most common arrhythmia you would see in your entire practice. Um, you'll have rhythm is the atrial, versus ventricular ratio will vary. You won't find a P wave. I often say that if there is irregular heartbeats and you're finding it difficult to make out a P wave, don't struggle too much. Let's say you don't find P waves in a few leads, and then you find something that is looking like something that looks like a P wave, then most likely this is atrial fibrillation, right? So the QRS complexes are fine, they're normal, but the P wave, none. And the atrial to ventricular ratio is just greatly distorted. It's an irregular heartbeat. In atrial fibrillation, it is due to enlargement due to atrioventricular valve disorders. That it can be due to that, and that's why when you have somebody with an atrial fibrillation, as part of your management, you want to do an echocardiography to rule out valvular abnormalities, right? It could also be due to hypertension, coronary artery disease, COPD, congestive heart failure, myocardial infarction, hypoxia, drugs, tobacco. It's also important to make sure that they're not on caffeine, to also do thyroid function tests. They could have, anxiety, palpitations, irregular pulse, shortness of breath. But if they are not hemodynamically stable, then you will want to go in with your shock. So what we want to do when we shock is to deliver synchronized cardioversion, right? But also remember that when you're managing your atrial fibrillation, you're doing your CHA2DS2-VASc score to see whether they qualify for anticoagulant therapy. Now, this is your atrial flutter. Your atrial flutter relates to underlying heart disease. It could occur in hyperthyroidism, alcoholism. There's decreased there's decreased carbon dioxide, leading to hypotension, mental status changes, fatigue, congestive heart failure, shortness of breath, and sometimes many times they can be asymptomatic. The nursing action is you document the rhythm. Now you can see this. This is an extremely rapid atrial rate, and you have your classical sawtooth, your sawtooth configuration, right? And then we talk about whether this is a 2-to-1 atrial flutter or a 3-to-1 atrial flutter, in which case this looks like the latter. Now, you'll also find your SVT. Your SVT is the impulses they originate above the ventricle. So what you have with your SVT is the fact that you have your narrow complex tachycardias. Now, if and there's usually an algorithm that I like to explain or show, but in the algorithm, the first thing you do when you're having, so you ask yourself, is this a normal rate or bradycardia or tachycardia? If this is a tachycardia, are the QRS complexes narrow or wide? If they are narrow complexes, are they regular or irregular? If the narrow complexes are regular, ask yourself, could this be a sinus tachycardia or could this be a supraventricular tachycardia? If they are wide complexes, could this be a ventricular tachycardia? If they are narrow complexes and irregular, then you're thinking, is this an atrial flutter or is this an atrial fibrillation? So in SVTs, you have narrow complex tachycardias that are regular, and it can be a bit tricky in practice trying to figure out whether this is a sinus tachycardia or an SVT, but the rate usually gives it away. In an SVT, it's usually between 140 to 250 beats per minute. The P wave is often hidden inside the T wave, so you cannot tell whether this is a P wave or a T wave, as you can clearly see. The PR interval is not measurable, and this would tell you that this is an SVT rather than a sinus tachy. So in premature atrial tachycardia, which stroke is supraventricular tachycardia. Supraventricular tachycardia means that these rhythm or these impulses are originating above the ventricles, and that's what you actually want. The impulses should originate above the ventricles, right? They should come from the sinoatrial node, but it is used to describe this unique type of tachycardias that are not sinus tachycardias. Then you also have the junctional dysrhythmias. In junctional dysrhythmias, the rhythm originates from the atrioventricular junctional tissue. It can be an escape rhythm. It could be um enhanced automaticity of the atrioventricular node. So if the sinoatrial node is sick, for instance, you would have this enhanced automaticity from the atrioventricular node. And because the atrioventricular node is taking over generating the rhythm, what you'll have is a slower rhythm, about 40 to 60. And then the P wave is inverted, or it could be non, or it could be retrograde when you have your junctional rhythms. The PR interval is shortened, right? The QRS complexes look normal, and other features are normal, except for the distorted P wave, which can be inverted, non retrograde, and the rest. In accelerated junctional rhythm, what you have is what looks like your junctional arrhythmia, but normal heartbeat. So the action is same thing as your junctional rhythm. Then your junctional tachycardia, you have what looks like your benign early repolarization. I mean, what looks like your J wave, your smiley phenomenon. But you've got to be careful here because you would think this is a ST depression. Note that in most cases of tachycardias, you'll have a level of ST depression, which would be normal. But this is the picture. Now, I try to go other um I try to go other the types of arrhythmias or the types of abnormal rhythm that would help you get conversant with this so that you will clearly identify an abnormal rhythm from an artifact. And you can see how it all clearly looks like an abnormal rhythm rather than an artifact because you can reproduce this across the strip. It's not just occurring in one lead, right? So in bundle branch blocks, you know about your bundle branch blocks. It can occur in your MI, ischemia, in a chronic conduction disorder. Sometimes there are no clinical signs. So you document the rhythm, notify it. Now note that a bundle branch block can cause you to be having ST wave changes that may mask an acute MI. Okay. Now you talk about your second degree ad blocks, um your second degree ad blocks. Um There's quite a lot to go through here with your atrioventricular art blocks, right? You're talking about your first degree, right? You're talking about your second degree and Mobit 1 or Weckenbach. You're talking about Mobit 2 or type 2. I will run through the rest now because there are quite a lot of abnormal rhythms and you need to familiarize yourselves with them. In Mobit 1, it can be caused by medications, and gradual what you have is the PRI interval can be normal or prolonged, right? Normal or wide. So, not that in your first degree ad block, your PR interval is consistently prolonged. In your second degree ad block, your second degree ad block in Mobit 1, what you have is what we call the Weckenbach phenomenon. And what you have in Mobit 1, I'm not sure the slides are well ordered, but in your Mobit 1, you have a gradual prolongation of your PR interval, right? And in Mobit 2, the PR interval stays the same, and then you have a dropped QRS bit. Then you have your ventricular bit, you have your premature ventricular complexes, which you should get familiar with. And what you will find here is that the QRS is just odd, one odd prodigal son that in which the QRS is wide and bizarre. The T wave goes in opposite direction in the wide QRS complex, and that's what alerts you to a PVC. Also, note that how you can find a bigeminy in PVC. Do you see this? Do you see this? This is a bigeminy in PVC. See this as well. It's occurring in the negative deflection. Then look at a quadrigemini. You have this going on here, as well as in the anterior legs. Then couplets, PVCs couplets. You have about two PVCs going back to back, right? And what you have is the causes electrolyte abnormalities, caffeine. If they are symptomatic, if you have six PVCs in 1 minute, it's pathologic, right? And if you could treat with lidocaine following procainamide, but I advise that you leave this to the cardiologist to institute. And of course, you know your VT, wide complex tachycardias. If they are polymorphic, you are thinking of Tosade's the points, right? And in which it is sinusoidal, looking like radio waves. And then you have your V tachycardia, right? Then you have your sorry, this is your ventricular tachycardia. Yes, I did mention that. Then you have your idioventricular rhythms. This is what your idioventricular rhythms look like. They are agonal rhythms occurring. They are bizarre. The P waves, you do not find P waves. Rate is 20 to 40 minutes. With this, you actually want to pay close attention because agonal rhythms could many times result in asystole. Of course, we've mentioned Tosadis the point. It's a type of polymorphic VT where you have sinusoidal you have wide complex occurring in different amplitudes, but in a kind of predictable amplitude. We talk about Tosadis the point. Then, of course, look at this chaotic rhythm. This is a ventricular fibrillation, and this is what I was referring to earlier. Now, this is asystole. If you get this flat rhythm and they're handing it to you casually, then you should question it. What's going on here? Because this belongs to a dead patient. What are you giving to me? Definitely. So misleading the rhythm strip case, they looks like VF. One lead shows regular QRS, but the patient is alert and talking, right? It could be an artifact from arm tremors. So never trust the monitor alone. What about real arrhythmias? In ventricular fibrillation and ventricular tachycardia, you have wide bizarre QRS and there is no pulse, right? Even when you have a VT that there is a pulse, many clinicians, many senior clinicians, or there's now been a consensus that has not yet been put into our guidelines for now, where people are able to shock VTs with a pulse because the algorithms will say shock a VT only when it's pulseless. Atrial fibrillation, if it's irregularly irregular, but the QRS is visible. SVT, you'll have fast narrow QRSs with hidden P waves. Asystole flatline confirmed in two leads. If it affects all leads, patient is usually symptomatic and the pulse correlates. The patient first rule, and that is why I tell you that in my RAIC formula for reading any ECG, for being comfortable reading any ECG, the context is king. Are they awake and talking? Is there a pulse present? Do they look calm? The ECG should match clinical reality. In an artifact, it won't affect all leads, but the arrhythmias will affect all leads. The QRS morphology is erratic in artifact, but it is clear in arrhythmias. Pulse is present in artifact. It may be present or absent in arrhythmias. The patients do not have symptoms in artifacts, but are often unwell with arrhythmias. And the repeat ECG resolves the artifact problem, but it doesn't resolve the arrhythmia problem. So the algorithm scan the leads. Are there any leads unaffected? Is the rhythm strip consistent or is there noise there? Check the patient. Are there alerts? Is there a pulse present? Repeat the ECG. Does the artifact disappear? So you spot the artifacts, right? The final takeaway is that you match the ECG with the clinical picture, and artifacts are common. They are quite common. Be the doctor who calls it out. Judgment matters more than the monitor. And that would be the end of this presentation. Thanks for staying with me.